Hello, everyone. Can you hear me?
Yes, we can.
Okay, all right. This was actually a session for medical and surgical SHOs and registrar, a recorded one, but I shared the group in the hematology groups as well in case they have any question or they have anything to add to it. Um, because we are overwhelmed by the bleeps or alerts from the SHOs and registrars, and I thought I should make a small presentation about it. So my name is Amir. I'm the hematology registrar in Mid-York Hospital, and this session is basically for medical and surgical registrars and SHOs. The purpose of the session is to explore common hematology bleeps or alerts. Some of the hospitals in UK they use alertive system when they send an alert to the hematology registrar or consultant via the alert app. Some of the hospitals in UK they use bleep system, and some of the referrals are online, which is called e-consult. This is the range of different um, topics about which we receive bleeps or alerts from the non-hematology team, especially about high counts or low counts, or if the coagulation profile is abnormal, especially if they are high PT or high INR or high APTT. We receive bleeps from them uh, to address their concern. Lymph nodes quite common from surgical people because they do CTs for their patients, and because of the ongoing ischemia or infections over there, they usually find lymph nodes, and they ask us whether this is lymphoma related or reactive lymph node. Splenomegaly, you may receive a lot of bleeds from the hepatology team, which deals with the cirrhosis, and they usually get um, splenomegaly on their scanning. Bleeding thrombosis, high ferritin, recently very common high ferritin because of the HLH. Everyone fears that this may be an HLH, so ask help from hematology. High MCV, different causes, especially this bleed comes from the GP because patients are on hydroxycarbamide or they are having MDS. So once the GP repeat the bloods, their MCV is high, and they call us that this patient is B12 or folate deficient, or what should we do? Again, heritable thermophilia requests a lot from the stroke team and neurology, because when they deal with any CVST, which is usually common in young females, and the stroke people, if they are dealing with ischemic stroke, they would ask for heritable thermophilia screen. This is not the exhaustive list. There are a lot of other random topics as well about which we receive bleeps from the non-hematological team. So not every abnormal blood count is a blood disease. Sometimes the answer lies beyond the marrow, which means that when you ask about any hematology related abnormality in the bloods or in the examination, which means lymphadenopathy, we always ask you certain questions which are related to secondary causes or reactive causes of that abnormality. For example, if HB hemoglobin is high, we ask you question to find out other causes of high hemoglobin in the patient. If the platelet counts are high, we ask you question whether there are any secondary causes of high platelet in this patient or not. So majority of the time, the answer is reactive, but still we do investigations first to exclude them. Um, and then if the secondary causes are not present in a patient, then hematological investigations come through. We will discuss certain cases to find out what type of bleeps or alerts we receive from the medical team. This is the first case. This is a 50-year-old female was admitted with severe community-acquired pneumonia, and the blood counts are given as hemoglobin 120, white cell count is 16, neutrophil count is 13, and platelet 480, CRP 300, no background medical and surgical history. We were contacted that this patient is admitted since 3 days or 4 days, and the platelet counts are on higher side, and uh, they are slowly rising as well. So the first question from the acute medicine consultant was that whether this is any malignancy, hematological malignancy, because of which the platelet counts are high in this case. So as per the BSH guidelines, British Society of Hematology guideline, there are very common secondary causes of high platelet. We always exclude them first before we go to hematological investigation. From the guidelines and from the research, we know that the iron deficiency anemia, any ongoing infection or chronic inflammation or acute exacerbation of any autoimmune disease, they are the commonest causes of high platelet count. Their platelet count may reach 1,000 or above 1,000. It does not mean that this is a hematological disease. If iron deficiency anemia is addressed and the iron levels are now normal, infection is treated, and inflammation has gone down till the platelet count is high, yes, then I would send a sample to my diagnostic center to find out if this is from bone marrow disease or not. If there is a secondary cause, which in most of the time is infection in our setup in the hospitals, or from gastrocyte, it is acute exacerbation of autoimmune disease. Usually, their patient develop Crohn disease exacerbation or ulcerative colitis exacerbation. Then we get high platelet count. We advise them, please treat the secondary cause, which is infection or inflammation or iron deficiency anemia, and then we have to, and then if the counts are still persistent, then we will um, send the sample to our diagnostic center for excluding the malignant cause. Similarly, this is another case which was referred to us for abnormality. This patient is a 50-year-old male admitted for being unwell. Background history of alcohol-related liver disease. Hemoglobin 110, white cell count is 4, platelet is 90, ALT is 141, and INR is 1.8. We were contacted that this patient platelet count is low and INR is high. We have given this patient vitamin K as well, and it is not coming down. What to do with that? So if your patient has liver disease, your liver is affected, and the patient is having is alcoholic as well with deranged LFTs, high bilirubin, it means that your liver function is affected, is abnormal. The clotting factors will not be produced in the same amount as it is produced in a normal person. So whatever blood tests you do for the liver, they will be abnormal. Once the liver function is affected, the INR is not reliable. So if the ALT is high, bilirubin is this much high, and then you think that the INR will be normal, it is not possible. You have to address the liver disease first, then you can address the INR. This patient has alcoholic liver disease. This is an acute disease. Once the acuteness of the liver disease is over, ALT bilirubin comes back to normal. The INR will come back to normal as well. But if the patient develops cirrhosis, which means chronically abnormal liver disease, then it is less likely that the INR will come back to normal. We had a lot of discussions with anesthetics and surgeons in chronic liver disease patients. because their liver functions are abnormal and they want us to normalize the INR, which is not possible. If you want to give a lot of FFPs or platelet, you are risking your patient for GI bleed. So abnormal INR or high INR, liver disease is the topmost reason. If your patient is on warfarin, yes, INR will be high. If the patient has vitamin K deficiency because of celiac disease, Crohn disease, intestinal surgeries, or if the patient has infections, this INR will be abnormal. It does not mean that this patient has any hematological disease because of which the INR is abnormal. Because if the INR is high, your PT will be high as well. The INR calculation depends on prothrombin time. So if INR is high, prothrombin time will be high as well. To address the liver disease, address the vitamin K deficiency or infection, give the patient vitamin K, then INR would come back to normal as well. The third common scenario from the surgeons and the gastro people usually, a 50-year-old man is admitted with abdominal pain. So they have done the CT scan, and the CT scan shows mesenteric lymph node. So when someone sees any lymphadenopathy on any type of scan, they will ring hematology, whether this is lymphoma or not. So lymph nodes are not enlarged only in lymphoma. There are other causes for lymphadenopathy as well. If this patient has infection, the lymph nodes will react to it, lymph nodes will get enlarged. If this patient has acute inflammation, the lymph nodes will get enlarged. Rarely, if the patient has a solid organ cancer involving the abdomen, this patient is young, less likely to have colon cancers or intestinal cancer. But if this patient has any colon cancer, intestinal cancer, or any intra-abdominal cancer, the lymph nodes can be enlarged in reaction. So the white cell count is 16 here, and neutrophil count is 14, which suggests that there is some infection or inflammation going on. The hematology will advise you that please send LDH in the patient and whether this patient has any B symptoms or not. Are you suspecting any cancer in this solid organ cancer or not? All these questions. But we usually ask them, please talk to radiologists whether these lymph nodes are reactive looking or these lymph nodes are suspicious for any malignancy. The radiologists are very good in telling us that. We always discuss the imaging in our MDT, and we ask the radiologist whether these lymph nodes are reactive looking or these are suspicious for malignancy. Should we biopsy them or not? If they think that yes, they are suspicious for malignancy, then patient should have some other features as well, like B symptoms for lymphoma. Or if the patient has a solid organ cancer, they should have symptoms according to that. Okay, LDH should be high. And as I mentioned, radiologists are very good in assessing in this, whether they are suspicious for malignancy or they are reactive. If they are suspicious for malignancy, they would themselves write in their report, please request lymph node biopsy for this patient. So lymphadenopathy does not mean lymphoma. The common causes are infection and inflammation. If the infection is settled, inflammation is settled, there is no solid organ cancer in the patient, CA screen, cancer screen, and we usually send CA 19, 25, and there is one more as well. If it is negative, then yes, then we usually ask the radiologist, should we biopsy it? If he say yes, then we request a biopsy. Another patient, a 50-year-old man is admitted with chest sadness. He is on apixaban 5 milligram BD for DVT, diagnosed 2 months ago. Hemoglobin is 129, white cell count is 15, neutrophil count is 12, and platelets are 40. So the registrars or SHOs would ring us. What to do with this anticoagulation. Platelet count is 40. Should I anticoagulate? Should I stop it? Should I change to something else? Or what should we do with this patient now? Because he has clot 2 months ago. So the first thing is that why the platelet counts are low. The platelet counts are low because the patient has sepsis, patient has infection. That's why platelet counts are low. We asked them what were the previous counts before admission. If they were normal and now it has gone down, so it is secondary to infection. But if they were persistently low, there may be a cause for that. It may be RTP patient, or maybe patient has a known hematological disorder that is leading to low platelet count. But if they were normal previously and now it has gone down, it is likely secondary to infection, as we discussed in case number 1. Then with the anticoagulation, if it was within first 4 weeks of a clot, we would have advised platelet transfusion. The first 4 weeks are considered as acute period. In this first 4 week, we transfuse the patient with platelet to keep them above 40 to give the patient therapeutic anticoagulation. But if the patient is um, not in this acute window period, particularly this patient is 2 months away from the clot date, we can convert the apixaban to low molecular weight heparin and can give the prophylactic dose to this patient. Prophylaxis we can give as far as the platelet count is about 30. Therapeutic dose we can give as far as the platelet count is about 50. Once the infection starts settling, platelet counts will come up. Once the platelet count is above 50, I can convert prophylactic dose to therapeutic dose of low molecular weight heparin. And after that, if the platelet counts remain stable, then I can go back to apixaban. Why I changed from apixaban to low molecular weight heparin? Because if the patient bleed on apixaban, I don't have any reversal agent unless it is a GI bleed and significant GI bleed. But for bleeding on low molecular weight heparin, I have protamine as a reversal agent, which is very effective. So in such cases, we convert the apixaban to low molecular weight heparin where the platelet counts are going down or where the platelet counts are less than 50. So you can give prophylactic doses if the platelet count is above 30, therapeutic doses if platelet count is above 50. But if the clot is within 4-week window, then the hematologist will advise you to give this patient platelet transfusion to keep the platelet count above 50 and continue with therapeutic doses. Another case, a 50-year-old man is admitted with abdominal discomfort and vomiting. He has abnormal liver function and jaundice. The hepatology team has requested, this is OJD, sorry, not ODG. So the hepatology team has requested endoscopy for the patient. The platelet count is 39. What should we do with this endoscopy? So BSH has, British Society of Hematology has clear-cut guidelines about different procedures. They have been recently updated. And then every trust in the UK has their own guidelines as well. So we always refer to our trust guideline first. If there are no trust guidelines, then we refer to the British Society of Hematology guidelines. If they are less than that, if it is less than the target, then we arrange platelet transfusion for the patient. These are different targets for platelets in different conditions. If our patient is septic and the platelet counts are low, because sepsis leads to consumption of platelet, patient platelet count will be normal, but if he develop bacterial sepsis, the platelet count may suddenly drop down even to single figure. In such cases, we transfuse the patient with platelet if the platelet count is less than 20. Any septic patient with platelet count less than 20, transfuse. Lumbar puncture, we keep the platelet count above 40. In the endoscopies, we keep the platelet count above 50. Any major surgery or OGD, the platelet count is above 50. You may hear from your anesthetist or from your surgeon that this patient is going for laparotomy. I want to keep the platelet count above 70 or 80. If my surgeon or anesthetist say like that, I tell them that my British Society of Hematology, my British Society of Hematology guidelines says that the count should be about 50. But if your guideline says to keep it above 70, please document it so that I'm legally safe. Then epidural catheter, aim above 80. Neurosurgery or neurobleed, this is the only condition. These are the few conditions where we keep the platelet count above 100. Remember, cataract is a non um, non-bleeding surgery. We do not transfuse platelet or cataract if the platelet counts are low, if the platelet counts are 50 or 100 or 30 or 20. It is a bloodless surgery. Cataract is a bloodless surgery. The problem is that if a patient has, for example, ITP or a disease where platelet counts are, so for example, chronic liver disease where platelet counts are low and you try to make it above 100, it means you are transfusing your patient with a lot of platelet. Platelet bags contain a lot of plasma and it can increase the portal pressure. Once the portal pressure is increased, your patient is at risk of bleed, GI bleed. Okay. We have these cases in our hospital because people either don't know the guidelines or they are new in the training. They just have listened somebody that if it is eye surgery, make the platelet count above 100. No, cataract is the only exception where we do not transfuse platelet. If it is any rest of the eye, back of posterior of the eye surgery, it is clear cut mentioned in the guidelines. If it is the back of the eye surgery or any other complex surgery involving the eye, then we transfuse the patient with platelet. Otherwise, no. Multi-trauma patient, aim above 100. This is another case where a 55-year-old man presents with fever, cough, and abdominal discomfort, history of heavy alcohol intake, and the blood test shows hemoglobin 130, white cell count 12, platelet normal, ALT 82, ALP 150, ferritin is 600, transferrin saturation is 25%. So because the ferritin is 600 and patient was having infection and abdominal discomfort as well, we were contacted that this may be HLH because the ferritin is high. Yes, and in HLH, ferritin is high. But you may have seen patients in your experience that the HLH patient ferritin usually is in 1,000. Recently, we had a HLH patient a month ago where the ferritin count was 110,000. They are usually more than 10,000, 40,000 or 50,000 or 80,000 like that. And patient is persistently febrile. Patient does not respond to any antibiotics and the counts are going down. So the formula that we use for suspecting HLH in patient is 3F. If there is persistent fever, not responding to multiple courses of antibiotic, if the counts are falling, hemoglobin is dropping, white cell count is going down, platelet counts are going down as well. And then ferritin. The ferritin is very high. These 3F raise a suspicion of HLH. Then we go and do the bone marrow biopsy for the patient and request blood test according to the HLH screen protocol. So any patient with infection, the ferritin would be high because ferritin is an inflammatory marker. If I have a sore throat and you check my ferritin, it will be high. Okay, and if someone has pneumonia or someone has urinary tract infection, ferritin would be high. It does not mean that this patient has HLH. HLH has its own criteria that the hematologists use. Ferritins are usually very high, about 10,000 or more than that. The causes of high ferritin, it can be hematological causes and non-hematological causes. I mentioned hematological causes. Yes, HLH is one of the cause of high ferritin, but if the patient has thalassemias or if the patient has um, sickle cell disease or the patient has sideroblastic anemia, these are a few cases in hematology or hemochromatosis where the ferritin is high. And they are known patients, they are diagnosed very early in their life. But if the patient has infection, liver disease, alcohol, malignancy, inflammatory diseases, their ferritin will be high, but transiently. Once the secondary cause is over, ferritin will come down to the baseline. Another case, 65-year-old man is admitted with sudden onset right side weakness and aphasia. CT head and subsequent MRI had confirmed ischemic stroke. Heritable thrombophilia screen. This is a common request from the neurology consultants or neurology registrar or SHO that this patient has ischemic stroke. We want to do thrombophilia screen in this patient. Even if the age is 70 or 80, they would request thrombophilia screen. What would it change? Would it change anything? If the patient is positive for any thrombophilia, what would you do? Nothing. This patient would use the stroke-related medication, aspirin or clopidogrel, for rest of the life. Treatable thermophilia screen would not add anything. That's why the British Society of Hematology has um, updated its guideline about heritable thermophilia screen in the stroke. This is 2022 guidelines and copied from the guidelines as it is. So it says testing for heritable thrombophilia is not recommended in patient with stroke, regardless of age. Testing for heritable thrombophilia is not recommended in patient with arterial thrombosis because arterial thrombosis is a stroke, ischemic stroke, as the association between them and arterial thrombosis in adult is weak and would not alter the management. For example, if a patient has factor V Leiden mutation, so what would we do? Nothing. We are indicated testing for deficiencies of physiological anticoagulants should be performed only after 3 months of anticoagulation for acute thrombosis. You cannot send the blood test now because there is acute clot and the result would be positive. It will be false positive because all the heritable thermophilia factors would be absorbed by the clot, and in the system the level will be low. The guideline does not recommend heritable thermophilia testing in such condition. Another case, a 42-year-old man present with high-grade fever and fatigue. On examination, you palpate a firm, non-tender spleen 4 cm below the costal margin. New cardiac murmur on auscultation. There is no jaundice or lymphadenopathy. White cell count is 18, platelets 420, and blood film is neutrophilia. The medical team contacted us because this patient had splenomegaly and the platelet count is slightly high, white cell count is high. They were thinking this is hematological malignancy. We were saying this patient has high-grade fever, with elevated count, and there is a new murmur, this is likely an infection. There is no other lymph node, there is no jaundice in the patient to suggest hemolytic anemia or lymphadenopathy. So when they did the echo for the patient has infective endocarditis. The splenomegaly has a lot of causes. Big spleen does not mean that it is related to the patient would have myeloproliferative disease or lymphoma causing big spleen. So spleen can be big because of infection. There are a lot of causes of splenomegaly. Infections are one of them. Chronic liver disease is another of them. And the patient should have some other feature to suggest that this is hematological malignancy related splenomegaly. Patient should be very anemic, blood film should have some features, count should go down, either one line or all the lines of the count should go down. Then we can say that, yes, maybe this patient has hematological malignancy related splenomegaly. And if the hemoglobin is low and patient is if the hemoglobin is persistently low and the patient is jaundiced and the blood film suggests of hemolysis, then we may think maybe this patient would have autoimmune hemolytic anemia, so we would do that test for the patient. It depends on the risk factor present in the patient. So every splenomegaly is not a hematological disease. Splenomegaly has a lot of causes. Please exclude the reactive causes of splenomegaly. If you think that there are no reactive causes of splenomegaly in the patient, then contact hematology. Hematology would see the blood film. This patient would have blood film made anyway, because whenever our machine detects abnormal full blood count, the blood film is made for those full blood count. So common causes of splenomegaly are portal hypertension, infection. In rheumatology world, it is Pelty syndrome. If these things are not present in the patient, then yes, please contact hematology. They would investigate further for any myeloproliferative or any lymphoma related or autoimmune hemolytic anemia related causes of splenomegaly. Second last case, 69-year-old man is admitted with pleuritic chest pain and shortness of breath. He has colon, uh, stage 3 colon carcinoma, diagnosed 5 months ago, and is currently receiving adjuvant chemotherapy. 3 months ago, he developed a left iliofemoral DVT treated with therapeutic tinzaprine. On this admission, his CT pulmonary angiogram confirms a new pulmonary anticoagulation plan. So I brought up this case because it happened multiple times in my experience. The patient was using tinzaprine and he developed another clot on it. The medical team would start the Duox for the patient or warfarin for the patient. This is not the case. This is a wrong practice. Please contact hematology for this case. We have experienced that the cases for which hematology should be contacted are not contacted, and for which hematology should not be contacted are frequently contacted. If you start Duox in this patient, he has colon cancer, not resected. He has high risk of bleed. Obviously, medical team would not know this because this is hematology related stuff. But many such cases has happened where Duox were started in luminal cancer without hematology advice and patient readmitted with bleed. Warfarin started without bridging and patient developed organ necrosis or skin necrosis. So in this case, please contact the hematologist. So consider increasing dose by 20 to 25% after excluding the cause. This would be done by hematology. Duox and luminal cancers are not recommended. Warfarin and cancer-induced thrombosis, warfarin is not indicated in cancer-induced thrombosis. Duration of cancer-induced thrombosis, 6 months, and then review by the parent team. not by hematology. Hematology do not see provoked thrombosis. It is unprovoked thrombosis that are seen by the hematology team. The last case, 74-year-old woman with a history of previous venous thromboembolism is admitted with upper GI bleed. She was on apixaban 5 mg BD prior to admission. Endoscopy shows bleeding duodenal ulcer, which is successfully clipped. He is now hemodynamically stable with no further drop in hemoglobin over 48 hours and is tolerating oral intake. The gastroenterology team asked for hematology input regarding when to restart anticoagulation. So this patient was admitted because of GI bleed, and now the GI bleed has been um, addressed. Patient was on apixaban. In this case, if you start the apixaban after addressing the bleed on the next day or on the same day, there is a high likely chance that this patient will rebleed. And you never know whether the rebleed would be fatal or non-fatal. There are guidelines about restarting anticoagulation in a patient who were using anticoagulant. Because, for example, any patient with atrial fibrillation on anticoagulation, they can have GI bleed, they can have intracranial bleed, they can have hematuria. Yes, we stop the anticoagulant because of bleed, but when the bleed is settled, we do not start the anticoagulant the next day. There are certain protocols and guidelines for restarting those anticoagulant again. If this patient has a GI bleed and she has high thrombotic risk because of atrial fibrillation, maybe she is obese, maybe she is bedbound because of other comorbidities, then after 3 days, I can give her some low molecular weight heparin prophylactic dose and observe her whether she will rebleed or not. If she does not rebleed on prophylactic dose of low molecular weight heparin, I can slowly increase the dose after 2 days, after 3 days, till I reach the maximum dose. And then I can convert to DUA. I can bridge the patient with warfarin, whatever anticoagulant you want to start accordingly. But always start the low molecular weight heparin, and it should be in prophylactic dose after contacting hematology. The upper GI bleed, if the patient has a high thrombotic risk, we start the low molecular weight heparin in 3 days. 3 to 7 days is the range, depending upon the thrombosis risk. If the thrombosis risk is high, it should be in 3 days. If the thrombosis risk is low, it should be restarted in 7 days. But start with low molecular weight heparin prophylactic dose. If patient can tolerate this, increase the dose further to therapeutic level, and if therapeutic level is tolerated, either continue with low molecular weight heparin or change back to DUAC or bridge with warfarin as per hematology advice. We have seen multiple such cases where patient was on warfarin, admitted because of GI bleed, and remained admitted for 3 days off warfarin, and then warfarin restarted. Patient readmitted after a week because of necrosis or because of a bleed. Or sometimes they are admitted earlier than this because of a rebleed. This is the Peri-procedure table from the BSH guidelines recently published regarding stopping criteria of DUOP for the surgery purpose. We consider this table whenever you call us. We look at this table if the patient is on oral anticoagulant and then advise you. Antiphospholipid syndrome testing, quite misused in our setup. Any young patient or young patient with a stroke, or young patient with clot, we would send lupus screen in the patient. Yes, you can do lupus screen in unprovoked thrombosis, but you cannot do lupus anticoagulant. It should be antibodies. Lupus anticoagulant testing should always be done 3 months after the anticoagulation. Antibodies are not affected, but lupus anticoagulant is affected by acute clot. In some hospital, these requests will come to hematologist, which will reject it, but in other hospital, the request goes directly to the lab, and they do it. And when the results are abnormal, then they contact the hematologist, and hematologist has to ask the history again. It is false positive, you have to repeat it again then after 3 months to make sure this was the correct result. Then everything become messed up, because the guideline says that you have to do lupus anticoagulant 3 months after anticoagulation and then repeat it 12 weeks after that. It means that this patient would have three tests now. One, medics have done in the beginning. You will repeat it after 3 months. And if it is negative or positive, you will decide accordingly whether to repeat it after 12 weeks or not. These are a few indications where we do lupus screening according to the BSH guidelines. But remember, lupus anticoagulant is not tested in acute clot. It is always tested 3 months after that, 3 months after anticoagulation. The anticardiolipin antibodies and beta 2 microglycoprotein antibodies, they are not affected by acute clot. You can test them. This is algorithm from the BSH guideline related to cancer. It has very clearly mentioned if the site of the cancer is luminal, no to DO, and yes to low molecular weight heparin. This is the table for different procedures with the target of platelets. You can see that PICC line insertion, cataract, bone marrow aspirin, they do not need platelet transfusion. They do not need any target. The practice will usually be different. You may have seen in your hospital that they would say that we need platelet above 40 or 50 for PICC lines, and then you have to argue with them. And the guideline says that no to platelet transfusion in this case, or cataract does not need platelet transfusion. But they just mentioned to them this is the BSH guideline or our hospital recommendation. If you are a consultant or registrar, you want to transfuse this patient with platelets, and if the patient develop any symptoms secondary to platelet transfusion, which is usually transfusion reaction, TACO, or trolley, you will be responsible. You will see that they will not transfuse anything, and then they will proceed with the procedure. This presentation will be available on this website for everyone. Thank you very much. If you have any question, you can ask. Do you have any question among the listener? No? Thank you very